Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I wanted to update us on tools to monitor medication taking in HIV pre-exposure prophylaxis. I did this talk 5 years ago and wanted to see what was new. So this is what I'm sharing with you today. My disclosures, we're going to talk about things that aren't FDA approved for their use with clinical patients, some of which are research. These are going to be mostly in medication monitoring, less so in medication taking, but there may be some crossover into some non-FDA approved strategies. This is the AET's disclaimer. This is a new guide to terminology presented by NIH National Institute of Allergy and Infectious Diseases. Over the last few years, there have been some guidance around the words that we're using. There are some things in here that people may have conversations about. I just wanted to bring in the issue of how we're referring to medication monitoring. And I'm saying this now because adherence is no longer in the recommended terms. It used to be in the previous version that adherence was recommended over using compliance to reflect the active engagement in care. But what I have on the right is a explanation of why we are now also avoiding adherence or adherent with the recommendation to use continuity of treatment, continuity of care, and taken as prescribed. And it is, as you can read in the guide and maybe on my slide, that it's a complicated acknowledgement that a person's ability to take pills reflects not only their will to take pills, but a lot of structural factors that impact that. And so trying to destigmatize that. I have tried, and I was able to remove all of but one references to adherence in this slides deck, which Pam then caught. So I apologize in advance. This is literally just a couple weeks old, and we are all just learning how to say this. So again, trying to definitely avoiding using compliance when talking about medications, and also now trying to avoid talking about patients being adherent to their medicines. So what we're going to talk about today, I'm going to review some of the data between efficacy and pill taking, and then talk about some of the challenges about medication monitoring that are specific to PrEP. And then what I really wanted to dive into today was about these novel strategies that people had, particularly for oral PrEP and how to monitor medication taking. And two of the things that they are getting a lot of interest are ingestible sensors and urine monitoring. So this is review for everybody. This is a slide that I show in my PrEP 101 talks. This is a table showing the initial randomized clinical trials that were released in the early noughties and the early 2000s that showed a really nice relationship between what was shown to be efficacy in the modified intent to treat analyses. And then when they looked and saw whether or not tenofovir was detectable in specimens and people who were supposed to be taking tenofovir who had been randomized to tenofovir, that there was a really nice relationship, not surprisingly, between the modified intent to treat result and the proportion of the participants who had samples that had tenofovir detected. So if you are a graphic type person, that there's a really nice linear relationship. Again, if on the x-axis, the proportion of blood specimens that had tenofovir detected and the efficacy in that modified intent to treat. And so if people weren't taking the medicine, the result of how protective PrEP was very low. If people were more likely to be taking their medicine, PrEP showed a higher efficacy. This isn't surprising at all based on what we know over the last 20 years. PrEP doesn't work if you don't take it. You have to take PrEP pretty well in order to have protective effects. And then looking at this relationship in a little more detail and how we can say that PrEP is over 90%. This suggests 95%. The CDC says over 99% effective if people are taking it as directed. This is just data from the IPREX open label extension study. So one of the challenges with PrEP in particular is that we don't have a good surrogate marker. People with HIV, that we use viral load as a surrogate marker. Really what we're interested in terms of thinking about antiretrovirals is, do antiretrovirals decrease mortality? We can't measure, right, mortality. That's a very far down the line endpoint. So what we want are these surrogate endpoints. And what we've determined over the years is that someone who has an undetectable viral load, that's a surrogate marker for impact. Someone who has a detectable viral load is a surrogate marker for HIV morbidity and mortality. But there isn't the same thing that we can measure equivalent for HIV prevention. So what we have are self-report, pharmacy refills, pill counts, electronic monitoring, such as pill boxes and smartwatches. And then we'll talk a little bit about ingestible sensors and drug level testing. And what we know from the earliest studies is that self-report doesn't always correlate with drug level testing, and that people will over-report because of certain biases, that they want to appear as though they are taking their medicines. But that's often what we have in the clinical setting. We just have these self-report and simple measures. And I think some of the things that are really obvious, if your patient doesn't show up to appointments, they're probably not taking their medicines every day. If your patient isn't picking up their daily prescriptions, if it's a 3-month prescription and they're picking it up, every 6 months or so, they're not taking it every day. And then the recommendation from the most recent HHS guidelines for how you ask, and just like with HIV treatment, we should be asking this of folks who are on PrEP when they come in for their appointments. And this question is intended to acknowledge that daily pill taking is challenging. And so the recommendation is, many people find it difficult to take a medicine every day. And thinking about the last week, that's what's recommended in the HHS guidelines the last week. How many days have you not taken your medicines? You can switch it around to be more positive. How many days have you taken your medicines? And then some alternatives that we're using in research include, how many days have you not taken your medicines in the last month? Thinking that there may be some variation that occurs if someone's coming in for their appointment. Maybe they're going to take it more regularly. So maybe over the last month has that nice balance between ability to recall versus sort of some changes that will happen with sort of the white coat pill taking. Or you can ask them, how good has your pill taking been over the last month, with the qualitative, very poor to excellent. I'm not going to touch on these available tools. Much hasn't changed. Very little has changed regarding these in the last few years. So there's still our Wise pill, which is this device in the upper right that looks like a 1990s cell phone with a pill box inside that sends a signal to a server if it's opened. And if you don't open it, the server can send a reminder to your phone to say, hey, take your medicines. This still exists, as well as what you see on the left is MediSafe. There was some hope that these were going to be covered by various insurance companies. I think there was a period of time they were, but the data suggests that they don't actually impact when you give it to someone that doesn't actually have an impact on their adherence. There is a whole lot more data recently on these ingestible sensors. What you can see in that figure A is the pill that gets encapsulated in a gelatin capsule that has a radio frequency sensor. You swallow the encapsulated pill. The sensor is activated in your stomach. It sends a signal to this device that you have to wear, and then it's relayed by Bluetooth to an app. There is actually a digital pill that was FDA approved since now almost 10 years ago, but further development appears to have been stalled for ethics and safety concerns. You can also imagine that this isn't an inexpensive device, and so probably it's more likely to be used. I've heard of it being researched for things like hepatitis C, where you have an expensive treatment for a shorter amount of time, where you can encourage people and monitor their pill taking and then do counseling appropriately depending on the results. But again, I don't think we're going to see this for PrEP, although there is a researcher, Peter Chai, who is doing this work in Boston with PrEP. What I do think we're going to see more of over the next decade or so is difference and point of care drug level testing. So we've had this ever since the beginning in these research studies. We've collected levels in blood plasma of tenofovir diphosphate in PBMCs, peripheral blood mononuclear cells. and in finger stick dry blood spots, as well as some research doing it in hair because hair collection is non-invasive. And what you can see on the slide is that they all have different exposure windows. So plasma is the shortest. It really only tells what's happened over the last few days. And as you get to PBMCs and then dry blood spots, you have a longer window. And I always think about this like the difference between blood glucose and hemoglobin A1C, where you can determine medicine taking and how well blood glucose control has been over the last few months. Hair, I think, is really fascinating just because you're collecting hair. It has to be close to the scalp. Obviously, it's going to depend if people have hair and how long their hair is. But you can see that sort of the difference as you get further out and people's hair grows at a slightly different rate, but that about a centimeter of hair reflects about a month. All of these are really correlated, but they all use really complicated technology, not complicated technology, but technology that can't be done at the point of care. And so there have been studies that have looked at whether or not you can give feedback to people based on these results. But if you're getting results back in a couple weeks, it's not as helpful as if you're sitting right there with someone and they're saying, oh, I'm taking my pills. And you can say, oh, it looks like you haven't taken your pills in the last few days. So there's been a lot of interest in the last 5 years or so, about doing urine point of care testing and looking at tenofovir concentrations, which again are strongly correlated to plasma. Right now, what we have are short-term markers, which I'll show you on the next slide, but they're basically like, your pregnancy test, your standard test. They're ELISAs that have antibodies to tenofovir. And these are relatively inexpensive, and we have data suggesting that it's acceptable to patients. There are, I think, there may be more at this point, folks who are producing these tests. These are from Monica Gandhi's group. This was in the pharmacokinetics, looking at dosing, fixed dosing, and the probability of using different thresholds of tenofovir and whether they would be picked up. And I find this always challenging, so let me walk you through it. The goal of this was to maximize specificity. This was based on conversations with patients and participants, and they really wanted to minimize people who were inappropriately identified as not taking their pills as prescribed. So they wanted it to say, if this test says it looks like you haven't taken your pills in the last 24 hours, that people wanted to be pretty confident that that was true, rather than being more sensitive and identifying anybody who might have had some challenges taking their pills over the last few days, week, whatever. And what you can see is this threshold. They picked this one here. So calling anybody who had under 1,500 nanograms per milliliter as looking like they didn't have hadn't taken their pills in the last 24 hours. So 98% of people will truly be under this threshold. Or when they say you haven't taken it, that will be true. There will be a 2% false positive rate. And this has moved forward in a lot of different research over the last few years. And I've only named a few of these studies, but in IPREX-Olay data and the Partners PrEP data that was done by Jarrett Baton, that having a low urine tenofovir level predicted future seroconversion in their open label extension studies. And then more recently, not yet published, but Matt Spinelli and Monica Gandhi have both presented their study looking at using this urine point of care test and doing counseling based on these results, and that individuals in the group randomized to receive this testing in subsequent visits were more likely to have detectable results. And there are lots of ongoing studies and ongoing work. So this work with urine point of care tests in this tenofovir study is being done in postpartum women in South Africa, in men who have sex with men in California, in sexually active adults in Thailand. This work has been primarily validated with FTC TDF. So there's work going on for validation with FTC TAF, which is going to change the levels. And then there's, of course, interest in identifying potentially markers of longer term adherence. So rather than just have you taken it in the last 24 hours, but maybe getting to sort of that one month to 2 month where we can really look at long-term adherence. And then just a note, the last time I talked about that, there was a company that was formed to do this called You Are Sure that was recently bought by OraSure a couple years ago during the pandemic. And they have two tests that are available. One is the SureSight test that is available as a dried blood spot, which you can send to molecular testing labs, which is the one in Vancouver, Washington. And then they also offer the urine point of care test, but say that it is currently for research use only. But presumably they are, I know nothing about this, but they are probably going through the FDA process.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.